Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare professional. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted yet so profoundly impactful.
Hello, everyone, and welcome back to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they're unprepared to face. Today, we are diving into a complex but essential conversation: the tension between provider wellness and organizational productivity goals. As physicians and healthcare workers, we often find ourselves caught between the demands of compassionate patient-centered care and the institutional push for efficiency, RVUs, and performance metrics. These pressures are shaped not only at the bedside, but also in boardrooms and C-suites, where strategic decisions are made that deeply impact the lives of frontline clinicians. So how do we begin to bridge that gap? Is it possible to design healthcare systems where productivity and provider well-being are not at odds, but aligned? And what role can leadership play in fostering environments that support sustainable, meaningful work? This conversation, it's not about blame. It's about understanding and solutions. And to have it with us today, we're honored to be joined by Dr. Gregory R. Johnson, a nationally recognized leader in healthcare who brings a unique blend of clinical insight, executive experience, and a deep commitment to health equity. Dr. Johnson currently serves as a System Vice President and Chief Medical Officer at UnityPoint Health, overseeing clinical operations across 17 acute care hospitals and 19 rural affiliates. His leadership has helped restructure service lines and standardize practices to improve outcomes and care delivery on a larger scale. Prior to this, he served as CEO of Hospital Medicine and Chief Health Equity and Diversity Officer at Sound Physicians, where he led nearly 4,000 clinicians across 45 states, advancing quality metrics and equity-focused initiatives. He's also served on the clinical faculty at the McGovern School of Medicine and Texas Tech, and his influence extends to national organizations including the AMA, ACP, and the National Association of Health Service Executives. Recognized by Becker's Healthcare's Chief Medical Officer to know, and as one of the Black healthcare executives to know, Dr. Johnson brings a powerful perspective on both leadership and frontline care. His extensive experience and unwavering dedication to improving healthcare quality and equity make him a leading figure in the medical community, inspiring and advancing the field of medicine. Dr. Johnson, welcome to the show.
Thank you, Dr. Fatima. I really appreciate your invitation.
So we ask everybody when we start, what is bringing you joy in medicine today?
Well, I think what's bringing me joy in medicine is still what brought me joy with that first patient that got me into medicine, which is the fact that what we do is make lives better. We improve people's lives through the bringing of health, through the navigation of sometimes when our lives are coming to an end, but it's a privileged place to be when we get to bring life into the world, when we help people navigate what's going on in not only in hospitals, but just in their lives, because we know, certainly for me as a hospitalist, but also as a health executive, healthcare is scary. Getting sick is unpleasant. But we sit in this wonderful opportunity to help people get back to health, get back to their families, get back to their homes. And so I wake up every day joyful that I get a chance to participate in this wonderful profession.
Yeah, and that's awesome when you said, I wake up joyful every day because more and more clinicians are getting burnt out and not with that expression. So I want to kind of know about your journey because you said you're a hospitalist, so you are a clinician. And how was your journey transitioning into an executive role?
Yeah, I think, don't want to exhaust the entire time discussing the journey. I entered healthcare, so I'm the son of a physician that actually almost frightened me away from going into healthcare. I didn't see my dad a lot when he practiced. He was solo family practice for a number of years in an area of Austin, Texas that was in dire need of healthcare. And so he was always on call and his beeper was always going off. And as a kid, I was like, who wants to live like that? That life just looks so dramatic but you see, getting to grow up in that people's appreciation for everything that he did in terms of keeping them out of the hospital, bringing family members into the world, all of those sorts of things, and the value. For me, I entered medicine because of a patient with a stage 4 sacral decube and a urethral-cutaneous fistula. Not the most exotic patient in the world.
Yeah.
Most people pretty grossed out by what was going on, but what I saw in that patient was, and what happened with him in the summer program that I was before I entered medical school, was the fact that it wasn't just the science of healing him and bringing medications to make that wound better. And as well as I do, debriding a wound is not something that most people would choose to do. But watching how by healing him, his smell changed, which meant his family engaged him differently. And watching the care management team work with him, watching the nurses diligently make sure that they were interacting him to bring him and really reincorporate him back into society. I was hooked on healthcare, and to be able to do that, that's what got me through the front door in medicine. But then recognizing through my interactions with the Texas Medical Association and then the AMA as a medical student and as a resident, and recognizing all of the things that ultimately affect a patient, right? So we think about a patient when you're at the bedside and you're like, my head is down, but then thinking about there's healthcare policy that's influencing the way that this patient receives care and ultimately how we choose what options he or she has out in the community. And then recognizing that as I continued to advance and really study what was happening, that there were perverse incentives for the way that we were caring for patients. And some people were steering the way that they practiced because of those incentives. And for me, it became about how do you get yourself in a position to not only take care of more patients, but making sure that the systems of care that we were creating ultimately led to that original result, which is that people get better, they get reincorporated into society, and most importantly, and I say this as a hospitalist, people get to stay home, which is where they want to be. And so that was my migration, and I say it was population health before it became a catchphrase. But from taking care of 25 to 30 patients at the bedside at a hospital, to being a medical director, to being a regional medical director, to being a CMO, and eventually a CEO of a large medical group, and now chief medical officer within the system, where we have 8 million patient encounters annually. This is an opportunity to really align those structures of care to ensure that we're taking care of the patient. And to the point that you were making before, how are we being mindful of the people who are taking care of the people? Yeah. Because to the point that you made, whether it's policies internally or externally, how are these ultimately going to affect how we care for patients?
Yeah, and just diving into that. So have you explored this tension? So it kind of switched for you where you were working as a clinician and probably experiencing those problems and being in an executive position. How have you seen the tension, between the provider wellness and the productivity goals which show up in our healthcare environment?
I don't think it's exclusively on productivity goals. I think that the tension exists in a lot of places, and hopefully less where I've been and where I am. But it's really in terms of making sure that there's clarity around what are we trying to accomplish. So, my classic example, and you mentioned productivity, but I have been in places where people are like, oh, well, I just moved the decimal point. And there was nobody from the operations or finance side that understood that the implication of moving that decimal point made the change to, oh my goodness, let me explain to you, you're moving that decimal point made that physician now go from a reasonable day of seeing about 15 patients to having to see 25. That's not possible. And where I see the tension has been allayed is in the areas where there are operational leaders, financial leaders, but more importantly, physician leaders who really serve as that bridge and that conduit to explain to the finance people moving that decimal point has meaningful clinical implications, and vice versa, where physicians are making or want to make decisions that they may feel are in the best line of patients, but at the same time are literally financially impossible. And I very much see my role and people and my peers in those roles of sitting in a place where you can, you're acting as a translator, and you're ultimately in place of saying, operators and finance people, we can't just move that number. You need to understand the clinical implication. And now that we understand the goal, the physicians can actually help us to achieve that. And then vice versa, of physicians, we have to understand that no health system has endless money. So let's figure out how we're ultimately going to come up with a better conclusion.
Yeah. But from the finance side of it, how do you think we get there? Because as a clinician, so I'm purely a clinician. I'm no experience. And it almost sometimes feels like, whichever systems that we've worked in, they're more focused on the financial part of it. Maybe they don't care about my wellness, or they're not paying attention. And so how did we get there? And why do you think now hospitals are prioritizing finances more?
I don't think that they're prioritized. Let me speak from what I know. Do I think that some people prioritize finance? Yes. We hear all the time the term "no money, no mission." Okay, well, that may be true. Nobody on this side works for free. Physicians don't work for free, and health systems have to be able to do this. As somebody who works in a not-for-profit health system where people are like, oh, well, it's not for profit, but you make a profit. Well, all of the profits that we make are reinvested back into the communities and back into the hospitals. And so ultimately it means back into the nurses and everything else. I think that the tension becomes, and this is where I think that we have a critical opportunity. The tension really becomes in understanding what's changed in the economic environment that has forced people to be so focused on the finances. We're right now in the midst of, and not to get overly political, not leaning one direction or another,
right,
but we're in the midst of a dramatic discussion about what's happening with physician compensation over the last couple of years. And this is where I say policy matters. Physicians have had their payment, people say reimbursement, it's not reimbursement, it's payment, cut by the number one payer in the country, which is Medicare, over the last 5 to 10 years.
Yeah.
Well, what happens when you cut what you're paid for? To your point, the only way to make up for it is either figure out a different payer. Super difficult for doctors because you don't choose who comes through your door most of the time.
Right.
Or the second piece is exactly what you said. I have to see more patients, which isn't a sustainable future. And so it does mean that we meaning the health systems but the overall healthcare environment, have to figure out what are we going to do to be able to balance this, because we can't run around and just see 5 more patients. We're doing the best we can with what we have. So how do we make the dollars ultimately make sense? And I don't say that as a platitude, because the money does affect, and it was one of the biggest reasons I got into administration was I was like, this money thing doesn't seem to make any sense. What's happening?
Right.
And so health systems, and I know that certainly UnityPoint Health is being very thoughtful on the fact that we have to figure this out, and for the same reason that you mentioned, burnout is whether people want to recognize or not, burnout is an economic concern as well. If we don't have enough people, physicians to deliver the care, and we don't concern ourselves with that, we're just really creating a worse situation for ourselves. And so we do spend, one of our strategic priorities is to make sure that our team members, our physicians included in that, have an exceptional experience. And that means that we have to be thoughtful about what kind of productivity they have, how do we incentivize it, and how do we make sure that people have enough time to recover, because these are difficult jobs.
Yeah. And it sounds like you would agree that seeing 25 patients is not sustainable in that sense to bridge that gap, right?
Well, I will say this. I remember early in my career, I saw 150 patients in a weekend. I didn't remember what I did. And I was genuinely praying when we were about to hand off on call that I brought no harm to anybody. And again, when I say thinking about systems of care, I spend a bunch of time saying there's got to be a better way to do this because this isn't sustainable. And and God forbid that ultimately there's harm that comes from it. And so I won't speak for any individual specialty, but I will say that you have to be thoughtful about what is doable, and not just doable, but what ultimately allows you to get the best patient outcomes at a reasonable cost point. Because there's the flip side to that, which is seeing 5 patients a day isn't sustainable either in a hospitalist model. It may be in dermatology, but it's not certainly as a hospitalist.
What you said, it comes down to the fact that when you are seeing patients, you want to make the patients feel better, right? So patient safety, is like a big piece of it. And yeah, so not just the physician is burning out, but maybe the physician cannot provide good enough care, and that's moral injury, like that.
Yeah, no, moral injury, and we speak about administrative injury that goes along with that. I think that there are a number of articles that really cite. There are a couple of New England Journal articles that cite administrative injury, and the fact is that that contributes to moral injury, and you have to be thoughtful, certainly when you're sitting in a seat like mine, of what can we do to mitigate that, and how do we engage people differently to ultimately avoid it altogether when you can.
So as a leader, how do you bridge that gap then?
So it sounds simple. It's really difficult to execute, particularly in a large health system. The job one is engaging bedside physicians, bedside nurses, bedside APPs. So, I'm a huge Ted Lasso fan, and when lots of people say it, but I believe in the inverted triangle. I work for them; they don't work for me. My job is to figure out how do we ultimately take their expertise from the bedside, and how do we effectively implement it into the system so that way we can get fantastic results. My favorite example of that is what happened with our health system and the IV fluid shortage. Everybody suffered it after Hurricane Helene hit and recognized what was happening in the country. We we had a fairly rapid response, but we had 60 physicians meet every morning at 7 a.m. And why do we meet at 7 a.m.? Because that was when they could meet before they started rounds. And they were the ones bringing suggestions. And my job is to work with our supply chain and a system team to ensure that we were doing what they deemed best practice and what they felt that they could do and contribute. And it was, and the feedback we received from our physicians was, hey, this was a crisis. And as opposed to telling us what to do, you asked us how we could help. And we actually want to help more now than ever. So it's really ultimately about respecting what happens at the bedside, respecting that work, and then making sure that that is, that is infused in the decisions that we make as a system.
Yeah. Is it though challenging for you? Because you can't be looking at because there's a lot that goes at the bedside, and I know you have a lot of unhappy people too, maybe.
everybody has unhappy people.
Yeah, that's what I was gonna say.
Yeah. Everybody has unhappy people. Do we have more turnover than I want to see in our system? Of course we do. Do I want to?
Yeah.
Do I think that everybody is engaged the way that that we want them to be? No, of course they're not. This is the real world and not a fantasy book. But I think that the difficulty is, when we say respect the work, that means respecting time. And that means being very thoughtful and saying, I can't give you the 17 other scenarios. I have to distill things down into, let me sure you, Dr. Fatima, understand why we're asking you to do this, and let's engage you in the discussion. And then I'm also going to explain why we can't do everything that you're asking for, but these are the things that we can do. It's always going to be a balance for us to have those discussions. And, is my job to make everybody happy? No. Is my primary job to make sure people know why we're doing what we're doing and feel that they have the opportunity to make input 100%. And that's ultimately how I think we as a health system are going to be successful.
Yeah. Well, how do the metrics matter to you as the healthcare executive?
Yeah, I love talking about metrics because it usually is the easiest way that you can make doctors angry. But I think, what I like to do, and certainly my approach with engaging people around metrics and their importance, is to recognize a couple of things. And again, it gets back into the original policy discussion, right? So I don't make up star ratings. You don't make up star ratings. But somebody does, and they publish them. And who looks at star ratings? Our patients. Yeah. So do star ratings matter? I could make a huge argument on this call, and that I don't think they matter at all. They're talking about care from 2 years ago, and who knows if these metrics align. But our patients care because it's what they see. Do we have a job to maybe change those? I do think we do, and that's why we talk about getting involved in other organizations that can help that. But in the interim, what I'm trying to do is spend time, and not just myself, but the entire team, of saying, okay, let's distill down care into what do patients care about, right? As a hospitalist, I tell everybody the same thing. Okay, well, patients don't want to be in the hospital, so when am I getting out of here? Length of stay. Can something bad not happen to me? Mortality and complication rates. Can somebody explain to me what the heck is going on? It's not the entire patient experience score. It's about communication. It's not the entire score. Can I please go home? Can I please never come back here?
Right.
If I don't have to.
Yeah.
But now we've distilled it down. I can put in a process metric. And now when I'm engaging you or anybody else and saying, okay, well, look, we're trying to accomplish these things, and I'm not speaking about them broadly. You as a cardiologist, or you as an oncologist, or you as a gynecologist. Okay, of these 5 domains, what's the thing you can control? And what we've found is that by engaging physicians in that dialogue, they're like, well, A, you're speaking my language because you're at least acknowledging that the scores may not be perfect. B, you're engaging me in terms of saying what is my distinct part in this, not just some random top-down approach. And then one of the most important things that we do is give people a window of time to say, okay, now how can we, what do we have to do as a system to intervene to support you? Because if you come back and tell me that, and people think about, well, what does this have to do with the next thing? If you're telling me that our parking lot is more of a patient safety issue than our emergency department, where the investments go to fix it. And so it really is about engaging and distilling things down into a way where it's still clinically relevant. And then again, carrying that clinical relevance back into the boardroom and back into the decision-making arena, where we know that we're making investments that are clinically relevant and are helped to be prioritized by our physicians.
Yeah. And a lot of clinicians may feel, though, because a lot of these metrics are efficiency metrics. So when they're being asked to maybe work faster, because that's what the throughput is. So I get that. They're not able to spend enough time with the patients, and it's like a tough balance. Like, is that something you would talk about too?
Oh, yeah. When I came into this system, we had 140 separate metrics that were measured across all specialties and over 167 dashboards. And in partnership with our chief nursing officer and the senior team, we've narrowed those down to 26. And candidly, we're looking to do fewer because at the end of the day, we want to make it simple for what good looks like for our physicians and again, not just physicians, but advanced practitioners, the entire care team. We want to make it simple in terms of what does success look like? Is this achievable? And does this align with how I want to practice medicine? Because if we're not doing that, to the same point that you made at the beginning, all we're doing is burning people out and we're pointing them to the door. And again, as a health system, we can't afford to do that.
Yeah. Why do you think, I know you talked about seeing a lot of patients back in the day. Why do you think healthcare providers are burnt out, less resilient?
I don't think people are less resilient. I think that they're frustrated. I think that I think that people get really frustrated, and I think burnout. Yes, there are psychological components to it. Yes, there are other components to it. But I think at the end of the day, people enter medicine with a vision of the type of care that they want to practice. And when they are pushed to the point of providing a type of care that they can't envision themselves delivering, yeah, that's burnout, right? I have to get out of this situation. It no longer makes sense. And I should find something different to do because I hope most people went into medicine for the joy of it. Some people didn't. But at the end of the day, I think burnout is a symptom of the fact that as and I don't know that we have a care system, but when we deliver care, some of our challenges are really ultimately figuring out how am I going to be able to deliver this care in a way that makes sense to me and ultimately allows me to to go to sleep at night and wake up and look at myself in the mirror the next day and feel like I'm actually doing some good. And so this isn't about a resilience. Do I think that we need to revisit any number of things in healthcare? I do. I think we need to revisit medical education. I think we need to revisit the numbers of people that we're doing. I think we need to revisit, and I'm not shy of bringing up, I think we need to revisit the payment model of how we get people through to ultimately be able to deliver care. All of those things need to be addressed in order for us to modify where we are in healthcare. But this isn't simply about, you're not resilient enough and that the older generation is harder than you are. I think this is a reality of a situation where, candidly, I already shared it. The way that I practiced initially was not sustainable. It had to move. I think that we have to be thoughtful of the fact that these are human beings that are caring for human beings, and that creating the space, time, and funding for people to ultimately live productive lives both within practice and outside of practice, we have to consider.
What are your challenges? I just want to know, because from my perspective, when I'm seeing 25 patients at bedside, I'm imagining you in your room, an air-conditioned office in the C-suite. I just want to know what your challenges are and how you're thinking every day.
Yeah, so you mentioned it, right? I have 17 acute care hospitals and 19 affiliates, and there are thousands of physicians across really what is a 5-state footprint. Am I in my office? Well, funnily enough, I'm not in my office. I haven't been in my office in 2 weeks. And that's not because I've been on vacation. One of my principles is that given scale, I don't see patients every day. And so my obligation is to spend as much time as I can with the people who are. And that's not just my market chief medical officers, but it's with Monday, I'm spending all day with our team in our cancer team to really discuss and asking them 3 questions. This is my approach, which is what brings you joy in your job? What is our biggest opportunity where you are? and how can I help from a system level? And so do I have to be in my office, and do I need to be in with the senior team to make sure that I have the entire picture? I do, because again, you bring up we have a legislative team, and I go back to policy all the time. There is I have to scroll 4 times every day for every new executive order, new state law. I have to know this stuff, and I have to understand its implications. And then I have to understand what its implications go from the system level down to our physician at the bedside. And then my job is to figure out how ultimately are we communicating this through whatever channels we have, because it's not all on me. We have a wonderful team that's able to do this, but the job is really to be thoughtful about all of the impacts that ultimately, again, get back to that bedside, impact that individual who's caring for that patient. And if the system is making it easier or harder for you at the bedside to care for that patient, and where we're making it harder, my job is to help fix it. And where it's easier is to figure out whether or not we can replicate it. And that's how I see the job in administration.
Yeah. Yeah. Thank you for sharing that. I think it's important to know just what we're trying to do here is try to hear both sides of the perspective. And I think you're the perfect fit for, because you are a physician and clinician and hospitalist, and so you know both sides of the stories. Is there can you think of some realistic, like scalable interventions that you've seen in your own organization or your work in the past that could shift the balance between the physicians and the productivity and other goals without compromising care delivery?
I think, what's scalable. I mean, the first thing I say, what's scalable is actually physician involvement and engagement. And yes, I know that when we're discussing burnout and energy and time, right, the first thing is like, you're asking me to do more. Yeah. Well, I'm asking you to do something, and I'm asking you to be thoughtful about, people say, I can't pick my leaders, right? The system picks my leaders, or my group picks my leaders. Well, groups can be more democratic than you probably think they are, even if they're hierarchical. Yeah. I wasn't selected by the physicians at UnityPoint, but a number of them were involved and engaged in terms of the decision of where I would fit in and whether or not I was a cultural fit and brought appropriate. And I think it's figure out how you can get involved. People, again, are dismissive of the little things that go on, but on the hospital side, I was just thinking the other day about right, like people are like, oh well, yeah, I mean, they're making me sit on the P&T committee. Well, it's fascinating to me because there are some people that are so passionate about what's going on in pharmacy and therapeutics, and thinking that we're going the wrong direction, that they're willing to advocate at every level in the organization to ensure that these things are going through. Well, it doesn't take any extra time for you to go, hey, you know what, can you get on P&T because you care much about more about it than I do. Yeah. And again, if it's getting involved in your county medical society, or if you don't like your county medical society, if it's getting involved in ACP, these are local things. You need the CME anyway. Go stop in and just log your opinion. I think people spend way too much time saying that my voice and my vote doesn't count. And the simple fact of the matter is it does in more ways than you think. I get influenced by people every day, which is why I spend more time asking them questions than anything else. Your influence means something, and don't dismiss it.
Yeah. And I liked, I don't know if you believe in any other wellness initiatives that you've done in the hospital, but I like the fact that you're asking what's bringing them joy. I think it's an important question.
Yeah, I mean, there are all sorts of things. My prior role, it was the conversations in the hospital about what was meaningful for docs. You talk about well-being initiatives, and I think we spend so much time discussing what happens at crisis, as opposed to moving things up and forward and saying, what are we doing to promote wellness? Mm-hmm. So, right, are we talking about, let's talk about the basic things that we typically ignore as physicians. Are you seeing your primary care physician? Have you actually made sure that you're caring for yourself? Yes, you at work, worked with hospitals in my prior role to make sure that there were meditation rooms and just quiet spaces for the physicians to be able to do things. But there were other scalable initiatives that were in real time during the day that simply modified the environment to allow it to be more sustainable. One of my favorite suggestions that went on for years was recognizing that as a hospitalist, when you're going to the electronic health record, which we all know is a big area of frustration, and then they were getting inundated with people walking up to them, and recognizing that actually they made a demarcation in tape around the station. So when the physician was sitting down, this is a patient safety area because I'm entering in orders that affect patients' lives. And it was amazing what happened, that stress levels went down, communication actually improved, and people actually were able to complete their workday on time. It's little suggestions like that and being thoughtful about, like, what can I do that promotes wellness as opposed to focusing on crisis? And is this something that is affordable and sustainable? I've had people just say, can you just give me a coffee maker? And and we were like, what? That's the cheapest well-being intervention in the history of mankind. That's what we need. Of course, we can't do that. People want to do more exotic things, but like sitting down with your operations team and saying, what can we do and what the things are going forward? Most important, and what's absolutely scalable, and something I've been wowed on for UnityPoint, is simply making recognition of excellent work up front is a well-being initiative. And it's not recognizing, and you get this all the time. This frustrates me as a physician all the time, of, oh, thank you, Dr. Fatima, for coming in on your vacation to see another 25 patients. That's a terrible recognition. But sometimes it's, we had a physician in my prior practice, and you could tell the commitment was so genuine of, the team buying a pair of shoes for a patient because ultimately, thank you for showing a caring heart. And by the way, we're going to reimburse you. We love you doing it. And this can become its own initiative. Those are the little things of really understanding. And this is, again, the respect for the work at the bedside of, we're not looking for daily miracles. I don't want to see that. What I want to see is consistency. I want to see that you continue to care for patients. And if we're rewarding that, that is reinforcing well-being, because they like me for the important stuff. They don't like me for trying to be a superhero, which, is an impossible task. So all of those things is really focused on what we can do up front to avoid crisis, and help to just mitigate some of the stress that goes on every day.
Yeah, and something like you said that you could incorporate in your daily day, and you don't have to go out of the way.
Exactly.
I can see that you deeply care for just by talking to you. I know you care about your workforce. You care about the physicians, being a clinician yourself. I can see that in your conversation. When you are making bigger decisions, and you think across organizations, are they thinking about physicians when they're making those decisions, or the feedback that's been provided?
I think, of course, it's not all. And I have no ability to point. I only know what I know. I feel incredibly confident in what we're doing at UnityPoint Health, and the fact that there has been such intention by our CEO, Scott Kaiser, of ensuring that there's a physician and a nurse at every decision. And I'm not kidding. I remember sitting down and having a conversation about a parking lot, and all jokes aside, and it was the physicians who said, can you please fix that pothole? I've had 3 patients complain about it. I'd rather have that than the cath lab. I mean, he actually said, please give me the cath lab too. But he said, but let's prioritize what's going on here, because, and those voices aren't token voices at the table. It is understanding that there's nobody, we have patient family advisory councils at the local level, and we have all these structural things to ensure that patients go through, and we have, patients and families that represent are at the board level. But the people for the day-to-day decisions that have to be made by a health system, it's the physicians, nurses that are sitting at the table. And I can say with unreservedly that for my health system, that happens regularly. And I think many others too, because I think if people haven't come to that conclusion that I stated for you, that we're not going anywhere, and there will be no movement in the health system without engaging the physicians and caring for them genuinely.
Yeah, you're right. They need a seat at the table. So
Yeah.
Thank you for mentioning that. If you had a magic wand today, what's one change you'd make in our healthcare system in the United States?
Oh, I only get one. I mean, there's so much. There's so much out there. I think I'm going to cheat. I'm going to tell you three.
Okay.
I think number one, we need more of us. We have to revise our training systems to ensure that there are more physicians, and that doesn't just mean more medical schools. It means more residency programs to train them. Along with that, it is training about modern aspects of medicine. So that does include health equity. It includes how to take care of yourself, both personally and financially, as part of that education process. And ultimately, how are we going to take care of, how are we going to ensure that everyone has, and this is the health equity piece, is how does everyone get to the same ability to have similar outcomes? We're not going to save everybody. Death is a natural part of life, and this isn't about trying to save everybody, but it's making sure that we can intervene in the way that have enough outcomes. And so that requires research. Research requires funding, and it means that we have to be thoughtful about where are we investing as a society and a health system. There is no quality without health equity. There is no ability for us to function as the type of nation that we desire to be. The health of a nation, the health of the individual is ultimately the health of a democracy. And so I want to ensure that as many people get the opportunity to live healthy lives and to survive some of the other things that unfortunately come up as we age or encounter other things in our lives. And so, that's not one answer; it's a bunch. But I feel that all of those are important. I believe that people want to live better lives. I think that we need more doctors to be able to support that, and so that's why I started at the beginning of we need more of us. We need more of us to be involved. We need different level of training, and we need the ability to better understand our patients and our communities, and that means a bigger investment in healthcare.
Yeah, that's awesome. I think the equity piece is really important, and it's something I think we should do another podcast on because I know you're passionate about that. I have one last question before we conclude. It's a two-pronged question. I think, what advice would you give to physicians or who are feeling burnt out, who are feeling dismay about the healthcare system currently, just from a healthcare executive perspective? And what advice would you give to institutions that are genuinely trying to do better, but they don't know where to start?
Yeah, last thing first, because as I said, it's easy to say, it's not easy to do. We must engage our physicians, period. You're asking health systems. The chief medical officer role, as I see it, and certainly how I am getting the opportunity to live it, plays a vital role in terms of helping to be that translator and that pivot to make sure that we understand the clinical and financial reality, and leveraging that role to be able to engage physicians, nurses, nurse practitioners, the entire care team is absolutely vital. For those who are burned out, it depends on obviously your reason for being burned out. I think all of us at some point in time have to sit down and ask ourselves why we are where we are, and are we doing the thing that we're intended to be doing. But I think that I am hopeful because I tell people, and I spend a lot of time with medical students. We have GME programs and academic programs too, and I tell everybody, I don't care what's going on. This is the greatest profession that has ever been created. I can't imagine doing anything else, and I wouldn't, despite many mistakes throughout my career and difficulties, I would never choose to do anything else, because this is a fantastic space to be in. I think, from a burnout perspective, it's if you need a sabbatical, take a sabbatical. It's going to make it hard on health systems and everything else, but take the time you need to take to recover, to regenerate yourself, because we need you. And if you want to be committed, then also take the time to figure out where you can find an environment that is going to allow you to deliver the care that you want. And sometimes that's doing things the traditional way. Sometimes that's doing things in new and innovative ways to be able to approach patient care. But we need you. We need all the physicians at the table. We need your voice, and we need your care. And so if it's taking a little time, take the time. Yes, it's going to make it hard in the short term, but in the long term, you benefit, and our patients benefit too, and the health systems benefit a little.
Yeah. That was, I think, wonderful advice. Thank you so much for joining us for this meaningful conversation on Muted in Medicine. I think it was really, really helpful just to talk to you and listen to your perspective. And I'm really grateful to you for sharing that with us. We do have a tradition on this podcast that we close with a poem. And this poem speaks to the quiet strength of those who lead, not just for today, but for the generations that follow. So it's called The Bridge Builder by Will Allen Dromgoole. So it's kind of a tribute to leaders. So it starts like this. An old man going a lone highway came at the evening cold and gray to a chasm vast and deep and wide, through which was flowing a sullen tide. The old man crossed in the twilight dim. The sullen stream had no fear for him, but he turned when safe on the other side and built a bridge to span the tide. Old man, said a fellow pilgrim near, you're wasting strength with building here. Your journey will end with the ending day. You never again will pass this way. You've crossed the chasm deep and wide. Why build this bridge at evening tide? The builder lifted his old gray head. Good friend, in the path I have come, he said. There followeth after me today a youth whose feet must pass this way. The chasm that has been not to me, to that fair-haired youth may a pitfall be. He too must cross in the twilight dim. Good friend, I'm building the bridge for him. Thank you, Dr. Johnson.
It's a beautiful poem. Thank you.